Good morning, everyone. We are meeting after a long time in a webcast lecture class. Obviously, you're not able to see me, but you're able to hear my voice. I'm Dr. Suma, Associate Professor from the Department of General Medicine. As I have finished 4-5 classes in endocrinology, so next topic will be diabetes mellitus. I'll be taking 2 to 3 classes on diabetes mellitus. Today, in diabetes mellitus, I'll be talking about the introduction, then classification of diabetes mellitus, how to diagnose diabetes mellitus, what is the pathophysiology of diabetes mellitus, and how does a diabetic patient present to you clinically. What is diabetes mellitus? See, diabetes mellitus, it refers to a group of common metabolic disorders that share a common phenotype of hyperglycemia. So, it's a group of disorder. It is not a single disease entity. So, there is a common phenotype, that is hyperglycemia, increased blood glucose in our body. So there should be a complex interplay of genetic as well as the environmental factors in the causation of different types of diabetes mellitus. So the factors which contribute to the development of diabetes mellitus are two. One is the insulin deficiency. Insulin deficiency can be either quantitative or qualitative insulin deficiency. And the second factor is the increased glucose levels. It can be because of increased glucose production in the body or because of the decreased glucose utilization in the body. And all of us know that diabetes mellitus is the leading cause of end-stage renal disease, adult blindness and non-traumatic lower limb amputation worldwide. Also, diabetes mellitus predisposes to cardiovascular diseases. Diabetes mellitus in India is growing exponentially. The incidence is increasing exponentially, and very soon India is going to become a capital of diabetes mellitus. How are we going to classify diabetes mellitus? See, classification depends on the pathogenic process which leads to hyperglycemia. So mainly it is classified into 4 types. One is the type 1 diabetes mellitus. Second one is type 2 diabetes mellitus. 3 other specific types of diabetes. And the 4th one is the gestational diabetes mellitus. So this is the etiological classification shown in a table. Type 1 diabetes mellitus, again in that we have a subclassification of type 1A and 1B. 1A is immune mediated and 1B is idiopathic. Then type 2 diabetes mellitus, 80% of the cases are type 2 diabetes mellitus. And the third one is the specific type 2 types of diabetes, which occurs in 10%. So in specific types, we have genetic defect of beta cell function, which can be because of mutations in the various enzymes, or genetic defect in insulin action, endocrinopathies such as hyperthyroidism, Cushing's syndrome, acromegaly, then drug or chemical induced, steroids. These are the few examples for drug induced. Then infections, especially the viral infections like the mumps, which causes pancreatitis. Then uncommon forms of immune mediated diabetes mellitus like Stiffman syndrome, anti-insulin receptor antibodies. Then there are certain genetic syndromes which have associated diabetes mellitus. Those are examples: Down syndrome, Klinefelter syndrome and Turner syndrome. And the 4th one is the gestational diabetes mellitus. So in any diabetes mellitus, what we have to see is that there is a period of progressive worsening of glucose homeostasis. In our body, normally the glucose will be maintained within normal limit. So, but before the development of the full-blown diabetes mellitus, there is a progressive worsening of glucose homeostasis, which is followed by the development of hyperglycemia. And this stage is called as pre-diabetes stage. So if we take in proper terminology, in this pre-diabetes, we have an impaired fasting glucose and the other one is the impaired glucose tolerance. So you can see in this table, so types of diabetes is there in first column, like type 1, type 2, other specific types or gestational diabetes. So in normal glucose tolerance is when the fasting plasma glucose is less than 100, and 2 are postprandial plasma glucose is less than 140. Whereas pre-diabetes, so whenever we are telling impaired fasting glucose, that means the fasting plasma glucose between 100 to 125 milligram per DL. Whereas 2 hours postprandial glucose, if it is between 140 to 199 milligram per DL, then it is called as impaired glucose tolerance. Once the fasting plasma glucose is more than 126, then and also the 2 hour postprandial plasma glucose is more than 200 milligram per DL, then the patient will be entering a stage of full-blown diabetes, from pre-diabetes to diabetes. So there are other, whichever we told the specific types of diabetes, in that the few which is important is the MODY. MODY is nothing but the maturity onset diabetes in young. So there are specific genetic defects in insulin secretion as well as the action. So it is a triad. There is a triad to diagnose MODY. That means it has first one is the autosomal dominant inheritance. That means there is a family history of diabetes and the early onset of hyperglycemia. Usually the age of onset of hyperglycemia is less than 25 years. Very rarely even the hyperglycemia can occur in neonatal period. And the third one is the impaired insulin secretion. So this triad, if this triad is there, then the patient is diagnosed to have maturity onset diabetes in young. There are several types of maturity onset of diabetes in young. The important one are the type 1, 3 and 5. In type 1, there is a mutation in hepatocyte nuclear factor 4 alpha. Whereas in type 3, hepatocyte HNF 4 alpha, hepatocyte nuclear factor nuclear transcription factor 4 alpha will be mutated, whereas in case of type 5, HNF 1 beta will be mutated. And type 2 MODY, there will be mutation of glucokinase. So these are the few types of MODY which are important. So MODY, few types of MODY will respond to sulfonylureas and few may require insulin. Gestational diabetes mellitus is nothing but the glucose intolerance which is developing during the second and third trimester of pregnancy. So why does the diabetes mellitus will occur, or the glucose intolerance occurs in gestational period? That is because insulin resistance is related to the metabolic changes which occur during pregnancy. There will be increased insulin demands that leads to impaired glucose tolerance or full-blown diabetes. But whereas diabetes in first trimester is to be considered as a pre-existing pre-gestational diabetes, which is told by ADA, that is American Diabetic Association. So whichever the hyperglycemia or diabetes occurring detected during the first trimester, that should be taken as pre-existing pre-gestational diabetes. That is not called as gestational diabetes mellitus. Gestational diabetes mellitus is hyperglycemia during the second and the third trimester of pregnancy. So once the pregnancy is over, during the postpartum period, most of them will recover or their glucose levels will come to normal level in case of gestational diabetes mellitus. But 35 to 60% have a substantial risk of developing diabetes mellitus in next 10 years. And also the children who are born to diabetic mothers are at increased risk of developing diabetes mellitus in future in their later life, and also they are more prone to develop metabolic syndrome. So after these types and classification of diabetes mellitus, how are we going to diagnose this diabetes mellitus? So already we know in the previous table I showed you the normal glucose levels, impaired fasting glucose or impaired glucose tolerance, as well as the diabetes mellitus related blood glucose levels. But what we have to remember here is glucose tolerance. What is the normal glucose tolerance we need to see? See, glucose tolerance, whatever is there, glucose tolerance terminology, it can be divided into three stages. One is the normal glucose homeostasis, second one is impaired glucose homeostasis, and the third one is the diabetes mellitus. When you call normal glucose tolerance, normal glucose levels are normal. So fasting plasma glucose less than 100, postprandial plasma glucose less than 140 milligram per dl, and HbA1c less than 5.7%. So this is the clinical criteria for the diagnosis of diabetes mellitus. If the plasma glucose concentration, that is random plasma glucose concentration plus symptoms of diabetes mellitus are present. So plasma glucose concentration more than 200 milligram per dl plus symptoms of diabetes, or fasting plasma glucose level of more than 126, or 2 hour post load glucose more than 200 milligram per dl during an oral glucose tolerance test. So this is the clinical criteria to diagnose that patient is having diabetes mellitus. See, any one test should be confirmed with a second test. Most often fasting plasma glucose should be done. So this criteria for diagnosis should be confirmed by repeating the test on a different day. So we need to know what are the risk factors for the development of type 1 or the type 2 diabetes mellitus. See, in type 1 diabetes mellitus, there should be a genetic predisposition. So in an individual with a genetic predisposition, who already has a genetic predisposition, a triggering event like a virus or the toxin, they will trigger an autoimmune response, which leads to destruction of the beta cells, which is the main source of our insulin. It takes several years for the destruction of beta cell, and there will be a development of type 1 diabetes mellitus. So genetic predisposition is important in type 1. Whereas in type 2 diabetes mellitus, the risk factors are: if there is a family history of diabetes mellitus, if the patient is very much obese, habitual physical inactivity is there, and previously patient is identified to have impaired glucose tolerance or impaired fasting glucose, or patient is having hypertension and patient is having hyperlipidemia. These are the risk factors for the development of type 2 diabetes mellitus. What is the pathophysiology? See, in type 1 diabetes mellitus, it is characterized by an absolute deficiency of insulin. Why does it occur? It's because of the immune response, which destroys the pancreatic beta cells. If pancreatic beta cells are not there, then there is no insulin. But in rare cases, beta cell destruction is not due to this immune mediated reaction, but it could be idiopathic in very rare cases. So you can see in this picture. So if everything is normal, insulin producing cells, this is isolates of Langerhans in the pancreas. So insulin is secreted into the bloodstream. If these blue cells are the insulin producing cells. In the second picture, when these blue cells are replaced by black colored cells, that means the insulin producing cells are destroyed, then there is no insulin in the bloodstream. So it is an absolute deficiency. So there are 4 stages in the development of type 1 diabetes mellitus. First one is there is preclinical period with positive beta cell antibodies. Second stage, the patient will have hyperglycemia when there is 80 to 90% destruction of the beta cells. Then third phase is the transient remission phase, that is the honeymoon phase. So a little bit of remission phase is there. Then the fourth one is the establishment of the disease. That means diabetes mellitus is established, hyperglycemia is established. These are the 4 stages. These 4 stages are shown here in this graph. So the y-axis shows the beta cell mass and the x-axis shows the duration or the age of a person. See, you can see that as the age is advancing, the beta cell mass, which was up to 100%, so because of genetic predisposition and immunological abnormality, whatever the normal insulin release was there, so the beta cell mass is getting reduced first, but it is destroyed up to 80 to 90%, then only the patient will start developing the symptoms. Right, so up to the beta cells are destroyed up to 80 to 90%, the insulin release will be normal. Once it is 80 to 90% destroyed, then there is a slow decline in the insulin release. Then there is a remission phase which leads to honeymoon period where the sugars will be better controlled. Then again patient will go in for overt diabetes. What is the pathophysiology in type 2 diabetes mellitus? See, type 2 diabetes mellitus is characterized by, it is characterized by both. That means there is insulin resistance. Main thing, type 2 diabetes mellitus occurs because of the insulin resistance. Type 1 was there is deficiency, absolute deficiency of insulin. Here the main part is played by insulin resistance and some degree of insulin deficiency will be there, or there is beta cell dysfunction. So diabetes mellitus occurs when there is a diabetogenic lifestyle which is superimposed upon a susceptible genotype. So diabetogenic lifestyle is like the physical inactivity, excessive calorie consumption and obesity. So genetically susceptible genotype is the patient is already having a family history of diabetes mellitus. So they are already susceptible for the development of type 2 diabetes mellitus. So that is about the pathophysiology. So what are the laboratory tests we are going to do in a patient whom we are suspecting that the patient is having diabetes mellitus? So this all of us know that. So glucosuria, that means in the urine we are checking the glucose. Normally glucose should not be excreted through urine. So it's a semi-quantitative test. It detects the glucose in the urine by a paper stress. So the kidneys have a normal threshold for glucose excretion. So if that exceeds, then the glucose will appear in the urine. Second one is the ketonuria. That is to detect the ketone bodies in the urine by a paper test strip. That is also a semi-quantitative. Ketonuria usually we detect is done whenever the patient comes with diabetic complication. That is diabetic ketoacidosis, too much of hyperglycemia. So diabetic ketoacidosis is a complication of type 1 diabetes mellitus. Usually ketonuria is done during detection of ketone bodies in the urine, usually done in the setting of complication of type 1 diabetes mellitus. And important is that to confirm the diagnosis we require a fasting blood glucose. See, glucose blood concentration should be taken in the samples obtained after at least 8 hours of the last meal. So 8 hours of fasting is a must to check for the fasting blood glucose. Whereas random blood glucose, at any time you can take the blood sample to check for the blood glucose levels. Then the fifth one is the glucose tolerance test. That is nothing but the postprandial what we take. So what the recommended is 75 gram of glucose is given to the patient with 300 ml of water after a overnight fast. So then blood samples are drawn 1, 2 and 3 hours after taking the glucose. This is more accurate test for glucose utilization if the fasting glucose is borderline. So we are not taking the 3 samples. We will be taking only after 2 hours, only 1 sample we will be taking after 2 hours of the oral glucose tolerance test. The other test is the HbA1c. Commonly we call it as HbA1c, which is nothing but the glycosylated hemoglobin. So HbA1c, it is formed by the condensation of the glucose with free amino group of globin content of the hemoglobin. So whatever the globin component is there, globin chains are there in the hemoglobin. So this condensation of glucose will occur with the free amino group of this globin component. So normally it comprises 4 to 6% of the total hemoglobin. Increase in glucose blood concentration increases the glycated hemoglobin fraction. And this HbA1c reflects the glycemic state during the preceding 8 to 12 weeks. So we take it as 3 months. So usually HbA1c monitoring will be done once in 3 months. This is least done, that is the serous fructosamine, which is formed by the glycosylation of the serum protein, that is mainly the albumin. Since serum albumin has a very shorter half-life compared to, not very short, so compared to hemoglobin, it has a shorter half-life. So serum fructosamine, it reflects the glycemic state in the preceding 2 weeks. So normal level is 1.5 to 2.4 millimoles per liter when serum albumin is 5 gram per dl. So normal hemoglobin is, so if it is up to 4.5 to 5, then the normal level is 1.5 to 2.4, because the serum albumin also varies in different individuals. So definitely like it is like not very much reliable, and one thing, and the other thing, frequent monitoring requires. So during that period we can do the FPS, PPVS itself. So the more reliable test will be HbA1c. So we can advise the patient for self-monitoring of blood glucose, which is extremely useful for outpatient monitoring, especially for patients who need very much tight control of their glycemic state. Then they can go in for the self-monitoring of blood glucose. So a portable battery-operated device, all of you know that the glucometer, which measures the color intensity produced from the adding. If we add a drop of blood, the color intensity which it is produced to a glucose oxidase paper strip, it will detect the blood glucose level. So this you can see one touch glucometer is there. So this is a glucometer, that is an example of glucometer. There are so many other glucometers which are available, other company glucometers which are available in the market. So how the patients with type 1 or the type 2 diabetes mellitus are going to present to you? So type 1 diabetes mellitus, patient usually complains of polyuria, polydipsia, polyphagia. So that is a triad actually what we tell for a patient with diabetes mellitus. 3 P's: polyuria, polydipsia, polyphagia. So increased frequency of micturition is polyuria, polydipsia, that is increase in thirst, and polyphagia, increase hunger. So then the patient will have weight loss, weakness, dry skin, and ketoacidosis. See, most of the patients with type 1 diabetes mellitus, they will not be knowing that they have diabetes mellitus, and they will present to you with only complication. The main important complication, diabetic ketoacidosis. They will present to you for the first time with diabetic ketoacidosis. Then you will be the patient especially will be shocked to know that they are having diabetes mellitus. And type 2 diabetes mellitus, same 3 P's, that is polyuria, polydipsia, polyphagia. And most of the time nowadays what we are seeing is so many patients will be asymptomatic. So they can be asymptomatic also. And in our OPD practice, what we see, patient will not be ready to accept that they have diabetes mellitus when their blood reports come. So they'll be hesitant to accept that they have diabetes mellitus because they'll be asymptomatic. And fatigue is again the common. So weight loss can be there. So previously obese patient will be losing weight in case of type 2 diabetes mellitus. And most patients are discovered while performing urine glucose screening. So they'll be screened for something else. So they might have come for UTI infections or pneumonia. So if you do their urine examination, then their glucose levels will be very much high. So this is about class on diabetes mellitus introduction. So what is the definition of diabetes mellitus? What are the types of diabetes mellitus? Broadly we classified into type 1, type 2, specific types, and gestational diabetes mellitus. What is the pathophysiology involved? So how are we going to diagnose the blood glucose levels? You need to remember means accurately, which is very important. And as such, diabetes mellitus is very common, and it is the leading cause of morbidity mortality worldwide. We should be like knowing about diabetes mellitus not only from the exam point of view, but also for day-to-day practice. It is definitely required. Thank you so much. Next class I'll be taking on the treatment of diabetes mellitus. Thank you.